Today's program is a Compass MS Care program. My name is Stuart Schlossman. I'm president and founder of MS Views and News. I too have multiple sclerosis. It's been a very long journey, and that's why we do what we do. I wanted years ago to be able to provide information for all the people that were not getting educated from their own doctors, so we wanted to start doing educational programs that none of the other MS organizations were doing. So let's go a little bit further along, though. So since 2020, obviously, you haven't been doing much. You haven't gone to a lot of programs. Well, since 2020, when the world all shut down, we were fortunately able to continue doing our programs because prior to the pandemic, we were doing live streams. And when the world shut down, what were we going to do? Well, we'll just do a live stream. So we found that we did our first program. The doctor was in Dallas, Texas. We had almost 200 people online. And I just said to my video producer, Bill, who's back here in the background, I said, this is going to work. This is going to be great. All right. And all the sponsors, all the pharmaceuticals came out and saw the audiences that we were going to have online. So they said, this is going to work fantastically. All right, so it has. So this program today is Compass MS Care, Rural America and Underserved Communities. And we do this because we find that in many portions around the United States, they're just not getting the correct amount of information, resources, or knowledge about the many MS medications that are available or the services that are available even from the other MS organizations. So these are things that we do like to speak about at our programs. I'm not going to go on and on. Today's program is sponsored by Bristol-Myers Squibb, Novartis, Sanofi, Genentech, EMD Serono, and Banner Life Sciences. And you probably never heard of Banner Life Sciences, but I'm sure you'll be hearing a lot about them as we go forward. Also, the reason why we have all these sponsors is because they know how effective our Compass MS Care series is. It's not just all you that are here. There's 50 of you on, in person here today, which is fabulous. But we're also going to have hundreds online watching this, and then we archive everything to our YouTube channel. And I'm telling you live and for those that hear this, because if there's something of this program that you want to know about, instead of writing notes, you don't have to. It's being video recorded. It is going to be on our YouTube channel. So you can just go back and pay attention to the program as it's happening right now. You don't need to take notes. And then when we put out the program online, you'll get notification of it being online, and you can check back about everything about it and turn on your family and friends to the information that you learned today. In addition to our program sponsors, today, we had a lot of exhibitors, as you saw. We had Bristol-Myers Squibb, Sanofi, Banner, Janssen. Okay, Janssen's a new kid on the block also, basically, providing an MS medication. EMD Serono, Genentech, and Acthar were here, and I hope that you got around to see all of their tables. And for everybody online, well, you could just go to our website and find each of these and click on the various buttons to find out what they've got in their websites. All right. Before we get started, well, two things before we get started. First off, Dr. LaGanke is going to be speaking for 60 minutes, followed by a 45-minute Q&A. So right now, I want to give a little tribute to two people who were very dear to me that lived in Tuscaloosa. All right, their names are Ken and Susan Davis. And the reason why we first came to Alabama when we did back in, I think, 2011 or 2012 is because Ken and Susan Davis were asking me to come up here. All right, Susan had MS. Ken, also known as Bubba, became a very close friend of mine. Ken ran a lot of programs for us in the state of Alabama. When I didn't have to come here, Ken was doing it. And Ken just basically helped me out with every single one of our programs, whether it was in Alabama or Georgia. Also, when we were doing our programs at what they call CMSC, the Consortium of Multiple Sclerosis Centers Conference, which is a once-a-year annual event, Ken and Susan were always there to help us out with that, with our exhibition over there. Well, Ken and Susan passed in January, 2 days apart from COVID. All right. They had a family gathering over Christmas, and it wasn't just the two of them. They lost their mom. They lost a cousin. Several members of their family got very sick, but those people did survive. So 4 people in that immediate family did die of COVID, Ken and Susan. Susan was on some kind of ventilator. It wasn't an actual ventilator. It was something else, but I don't remember the name. She passed on a Friday afternoon. Ken called me 60 minutes after she passed to tell me what's going on and telling me, that they're going to have to wait on the burial until after he's out. Then I didn't hear from him Saturday, and then I didn't hear from him Sunday morning. And we got in touch with his daughter and found out that he passed Sunday afternoon. So, it means a lot to me. It means a lot, for Ken and Sue for all that they did for MS Views and News. And I just wanted you all to know this because, again, I just wanted to give tribute to the two of them. So, whatever. Now we'll start the program. All right. So we're going to have Dr. LaGanke. And Dr. LaGanke, I'm sure all of you know, and all of those online, if you don't know him, well, you're about in for a good treat. I've known Dr. LaGanke for many, many years. Dr. LaGanke has had MS in his family, all right, and he's got his own neurology center in Coleman, Alabama, where obviously he's the director, and the name of the center is Joan P. LaGanke MS Center. So I don't want to say much more about him because he's only got 60 minutes to talk, all right, but come on up and let's get this thing started, all right? Thank you.
Thank you. Stu does an amazing job. He probably educates more people around the country and some across the globe than anybody that I know about. He's always accessible and keeps these programs up and running so that people can attend them, and then he archives them so there's a record of them and people can go view them. And I talk about his site all the time to patients to learn more about it because I don't have that much time in clinic to spend to go over all the things that need to be gone over, nor do I have that in this 1 hour either. So I think there were 6 topics each. Could have taken hours to talk about, so I'm going to just kind of blow through and I'm going to get to what I get done, and I think it's the things that we have to say is very important. So as you can see from the title, it's going to be a soapbox and it's going to be pearls of wisdom that I hope to bestow. I love these venues. I'm unplugged, so I get to make my own slides. I get to talk about whatever I want to. And there's value in pharmaceutical based FDA regulated talks. There's information that's valuable, but it's very regulated and we don't have any input into that. So this is kind of from the heart, so to speak. And it is really personal. So the center that we have is named after my mom, and she had really tough course with this condition. So she had it before we had an advent of any treatment, and died from MS at the age of 62. So I know it from the beginning as a little boy. With a mom who was afflicted, to her having a cane and her mom there outliving her, which is a tough thing to do as a parent, to outlive your child. That's her at my UNC graduation, and then she died. So this is a fatal condition. We need to understand, with the advent of treatments, we've really been insulated from the treacherous disease of untreated MS. And 7 years lost life on average, untreated. So we know that, and this study kind of showed that. So this was the initial interferon beta study that showed people who started 46.8% reduction in risk of death over a 21-year follow-up period of time. And that was our first medicine that we had available. So we know that there's a normalization of life expectancy when we manage MS well. So I have a lot of important things to say. Why me? You might ask, get diagnosed, and I think that's a question that I address in clinic a good bit. Why did I get this? Why did I have to have this? And people carry a lot of burden with having had this. And thinking about it over the years, I've been to hospitals with 40, 50 people wailing in the hallway with the death of a loved one that I had to go address. And I've held the hand of many people who've passed, not MS necessarily. And I think I'm better for it. I can better care for my patients because I've had those experiences. No one would volunteer to be in that bed or in that ditch, so to speak. But they were, and they helped me to help you. And we need to remember that wherever you are, you have a lot of value. It may not be the way you thought it was going to be or what life should be or how you had planned it to be, but you still have immense value where you are. You're the only person with your fingerprint on this planet, right? So therefore, you can shine a light uniquely. No one else can shine it the way you do, no matter where you are, no matter what situation you're in. And I can't tell you how many times in clinic I have people who come up and give a story something like this. You know, big churches around here, the people on the east side don't know people on the west side so much. So in one particular instance, someone from the west side came over and hugged someone who had MS on the east side. And they didn't know each other, big church. And she goes, "You've inspired me, and you kept me going so many days of my life. I just had to come over and give you a hug. Because you get up and do, and you persevere with your challenges, that has saved me so much difficult times and allowed me to persevere when I thought things were difficult." I have patients who come in the exam and say, "If I have a bad day, I just think about coming to your exam room, and I'm inspired, and I have a better day." And examples go on and on and on. So where you're at, no matter what your level of disability, you have a lot of power where you are to inspire people in ways that talks like this or textbooks or lectures aren't going to shape people. So I was pretty well shaped. One person's impact. So my mom's illness made me a lot more compassionate. It changed my career. I wasn't going into medicine. No one in our house was a doctor in medicine. She changed those around me because she changed me. I've seen over 150,000 patients in my career, unique patients, and many of you several times. But 150 unique encounters that were impacted by her illness. Allowed me to educate. I've been to Australia and Tokyo and all over Europe and Argentina and here and there and everywhere and over the States, educating people about MS because of her disability. And allowed me to advance research into MS, which we'll talk a little bit about here. So if you don't think you can have impact being confined to a wheelchair and then a bed and then passing from this, you're terribly wrong. You have tremendous, tremendous impact in people, and you need to realize that. Don't give up. This is a very disabling condition, the number one disabling neurological condition in the world for young and middle-aged adults. Even with that, we have some difficulties in getting correct care. And part of the reason I stay in clinic till 8 p.m. several nights is because I have to spend a lot of time educating people about things that they should have been educated about. And they come in and they're advanced with their disease or have been started on a medication, allowed to kind of go along with their disability. And there's this therapeutic inertia, meaning that just not very aggressive care in a lot of situations. This prospect theory I'm going to go over in the next few slides is a fascinating theory, I think, just in life. It's how we make decisions with shopping and advertising and everything. But it's pretty fascinating and has great impact in what we do in the medical field. So I think some people follow that prospect theory so they don't render really aggressive care. And then there's this skewed Hippocratic oath. So our Hippocratic oath is first do no harm. So doctor's perspective might be, well, if I don't give IV antibiotics for a moderate to severe infection instead of giving a pill, I have less of a chance of harming them from a significant side effect from the treatment. And if they happen to be maimed or really harmed by this infection, well, the infection did it, I didn't do it. And move that to MS, well, I'm going to start a very mild medication, and if a person gets worse, then we'll go to the next. Well, that if a person gets worse means they have to live that way the rest of their life, right? And so I'm not doing any harm, and if they get worse, well, MS is a terrible condition. Well, I think a lack of aggressive care is also doing a patient a world of harm, at least not discussing it and offering it. So we have this safe place of, well, I'm not going to be terribly aggressive and talk about side effects and monitor these kind of things, and we'll see how it goes. That's sort of the attitude in a number of places, unfortunately. And then I see someone and they're in a cane for the rest of their life, and it's really disheartening. It didn't have to happen. So here's a prospect theory. Would you rather? So here's the question. Would you choose to get $900, or would you choose a 90% chance of getting $1,000 and a 10% chance of getting nothing? Secondly, if you're sure to lose $1,000 versus possibly losing 90% chance of losing $1,000 or a 10% chance of losing nothing, what are you going to choose? And if I go back a sec, so when we face risks, as far as when we look at rewards, we take less chance at rewards. So we accept a smaller certain award as a sure thing than take a risk. And that's been many, many studies looking at that in different ways. On the flip side, if we're going to lose something, well, we're going to take more of a chance. So people take more of a chance if they have a chance of maybe not losing something. So if you have a 10% chance of not losing anything, you'll take that extra risk of 10% worsening. And all of the choices have the same value, right? And that value is probability times the expected outcome. So in the first instance, you get $900 times 100% chance you're going to get that, that's $900. If you're going to get $1,000 90% of the time, that's $900, plus 0 times 10 is 0, $900. And it's the same with the other. All of them have the same probability. But it's amazing how such a high percentage gravitate to one answer and take the sure thing when it's a gain, and will do what they can, take risks to avoid a loss. They'll take a risk of even losing more. And that's in marketing. That's why you get a $10 coupon, and people will do that instead of going for a sweepstakes that could give them $25. I'll take the coupon. Thank you very much. So they do it all the time with all the shopping that everybody does. But that came from a theory in 79. So we kind of do that in clinic too. And we're emotional thinkers. We think in terms of how gains and losses affect our status quo, our comfort level. So a healthy smoker, I'm doing really well. I don't think I'm going to quit smoking, right? And sadly enough, my father-in-law's sister just found out she has stage 4 metastatic lung cancer everywhere. And she smoked, and she acknowledged it. She said, I took the risk, I know. But I think deep down, she probably thought she was going to get away with it because she was doing so well for so long. And how we frame a new lesion on MRI, same thing. You're feeling well, you're doing great on your treatment. Your MRI said you had a new spot or two. We need to think about changing your therapy. Ooh, I don't want to change my therapy. I've been doing pretty well. But as you'll see in a minute, that's maybe not the right choice. And then influencers have a lot of influence, don't they, these days? And they have a lot of influence by how they frame things. Half empty, half full. Same thing, you're getting half a glass of water. Some people are elated and some people are disappointed, right? So it's about framing. It's just how we think, and we need to think about risk-benefit of treatment, and there's a risk to under-treating somebody. And that's what's not factored in the risks. The side effect of this medication or this treatment is blah, blah, blah. But the risk of not treating it well is not necessarily factored in, and I think needs to be at least in the decision-making. But we don't do so well as clinicians in treating diabetes, hypertension, atrial fibrillation, multiple sclerosis. 50 to 70% of clinicians do not escalate therapy when the practice guidelines say it's best to do so. And you trust us to make those decisions. So it's good that you come out and you get educated, and you need to be an advocate for yourselves, because we fail you sometimes, okay? We have a high tendency to do what we're comfortable doing. Write the same prescription over and over and over again. And sometimes it's the right thing to do, but you need to discuss it with a vigor every time, and not just say, well, everybody's going to take this particular medicine. Well, we're going to talk about this particular treatment with you and see if this is right for you, but not this is what we do. And the other thing, I mean, this week, shocking, 3 MS centers, patients, came in and said, well, they gave me a bunch of brochures and asked me to decide what MS treatment I'm going to go on. That was the 90s. We did that in the 90s. We had the injectables, we gave them 3 videos and whatever, and whoever had the best marketing usually won the prize, right? But we didn't really have a lot of data on one being superior to the other, so that was about the best we had back then. That's not the case now, and I was just mouth, jaw drop kind of situation. They gave me 5 things and just told me to decide what I wanted to do. Yeah, that's why we're there, supposedly. So evidence-based medicine is ideal, and some of these slides you will have seen before if you've been to my talks, but I think they're important to reemphasize. If we had the evidence that this was the best choice for you, that's ideal. That's what we would love to have. But we don't always have that, so there's no study done to say that you should breathe on the day of a full moon, but you know what, you ought to probably breathe, right? There's no study to prove it, there's no evidence, but I think it's a good idea. And with that, we need to kind of look back at a very bright Dr. Ossler, Sir William Ossler in 1892, very appropriate still today. If it weren't for the great variability of individuals, medicine might as well be a science and not an art. Y'all don't follow the textbook exactly every time, right? So we have to be willing to modify, adjust, and do what we need to do to best take care of you. In making a diagnosis of MS, you can be 100% accurate. Wait till everyone gets to a wheelchair status and say, yep, you got MS, you have MS, you have MS. And we'll be very specific, and then we can diagnose everyone who has a white spot in their brain as having MS. And we're going to pick up a lot, but we're not going to be very specific in treating it. We're going to treat a lot of things that don't. So clinicians kind of vacillate on one side or the other what they feel comfortable with, waiting until someone, well, you know, you may have MS, you probably have MS, but I'm going to wait till this happens or that happens. And that waiting may render someone permanently different. And then on the flip side, you don't want to treat somebody who doesn't have the condition yet and they have a bad side effect of a treatment. So both sides, without a diagnostic test for MS, it's a little difficult. And so sometimes probably the best of us will go one direction or the other. It's the best we can, and we're seeking to do the best we can for the given individual at a given time. Part of the reason that clinicians who don't want to diagnose MS, and I'm sure there are a few of you in the room, and it took a while to be diagnosed, and we're told, well, you don't have MS, but I don't know what you have. They can be sure of the fact you don't have MS without a diagnostic test, but they can't tell you what you have, right? And a lot of times what they'll say is, have you ever had a migraine? Well, the migraine is causing your scars in the brain. Or if you're 50, you have heart of the arteries, that's what's causing your spots, because they're in this non-specific area between the ventricles in the middle and the outer cortex, and that's the deep subcortical white matter, and that's a non-specific area, so that's not MS. Well, several textbooks, and in preparing for this, looked at some of the older pathology books, and most of the new lesions and almost all of the active lesions that we see in clinic, when you come in with a relapse and an active lesion, they're in that deep subcortical white matter. They're not in the periventricular white matter or the juxtacortical white matter. Yes, it's when we see lesions in those areas, we're really thinking about MS as being the condition, but that doesn't mean that we ignore a predominance of lesions in the deep subcortical white matter and say it can't be MS because it's in non-specific locations. Well, that's where most of the activity occurs over time. And so I hear that a lot. Well, they said it's non-specific white matter lesions because they're in that no man's land. That's where MS really is active once you're diagnosed. So anyone know who that is? Hank Aaron, very good. So he broke Babe Ruth's home run record. And back around 2000, I started a talk circuit about the home run of therapy, because I said, well, what should our goal be? What would my goal be if I had MS? Well, I'd want the following. I'd want a treatment that's well tolerated and safe. I'd want to have no relapses. I'd want no worsening of my exam, and I'd want no changes on the MRI scan. We're not talking about repair, but just what would I want out of a treatment to keep me stable? Well, that's what I would want, those 4 things. That's the home run. And since then, someone smarter than I came up with a term for it, and they called it NEDA at some point, so no evidence of disease activity. Didn't include the well-tolerated safe part, but NEDA is a huge thing and what we strive for now, really as a MS community. And here's NEDA. So no relapses, no disability progression, no GAD-enhancing lesions, and no new lesions. So no active lesions and no new lesions, and that's NEDA. So most of our clinical trials have a NEDA component that we're looking for, because we don't tolerate new disease activity anymore. So the original medications that, thank the good Lord, they came and allowed us to at least attenuate the disease some, are not typically the right choice anymore because they don't come close to NEDA. Early relapses herald later secondary progressive disease. So we don't like relapses. The damage of the wiring, so this is a demyelinating condition. It strips the myelin, but it also attacks the axons or the wires themselves a fair amount of the time. And the highest time in your life of having axonal loss is when you have milder MS. And then it just degrades over time. So the early inflammatory, yes, I had opticneuritis, I got over it, and I may have had some numbness, and I got over it, I'm trucking along, I'm good, I don't need to take my treatment, or I can take this just really easy treatment. Not necessarily the right answer. Okay? The number of lesions at year 1 predicts how you're going to worsen over time. So that's why I chose those as parts of the home run. Lesions, even when they're asymptomatic, they predict long-term disability if you don't change what you're doing. Number of relapses early predicts long-term disability. And obviously, if your exam's getting worse, we're not holding you, then that's not a successful treatment either. And here, one other point with the MRI. Lesion growth in the first 5 years predicts what's going to happen, what your disability is going to be at 14 years. Okay? So early treatment, when you're feeling kind of good about things, really important to stay vigilant that we're keeping as great a control of this disease as we can. And relapses aren't so friendly either. So there are two studies, Hurst and Lublin, show the same thing. About 50% of people in the 40s will have a neurological worsening of at least a half a point. 30% at least 1 point on our 10-point disability scale. And what I say is you'll never be the same again. So 50% of the time after a relapse, you're going to have something that you carry the rest of your time. So I'm not a big fan of, let's start this mild disease, and okay, you've had some relapses, now we can go to the next thing. Well, you're not going to walk this planet the same again. Is that right? Is that the right treatment choice? Don't know. And then if we can really control it, so to further that point, if we really get great control of your disease for the first 2 years, you have a real good chance of having no disease progression at 7 years. And it's common to have an inadequate response because of therapeutic inertia and not this, we're going to control this disease kind of attitude. Okay? So you can see here that many people break through suboptimal response treatment failure. Anybody know who this is? This is Dr. Sharko. So he named MS back in 1868. And 125 years later, we had our first medicine that changed the course of MS. long time waiting. My mom's life waiting, right? But we had a win, right? And I went to North Carolina, and I went to the Duke bye-bye game, so I have to put it up there, so sorry. And the first treatment was beta-seron. So this is the first medication that we had available to alter the course of MS. And now we have this, and I couldn't fit them all. I tried my darndest, and it's not a pretty slide at all, and whatnot. But this is our 23 agents that we have available for MS. So it starts with Avonex that's tucked up under the top, one of the first agents. It's an intramuscular shot, and really gave us a lot of information about clinically isolated syndrome and the first attack of MS, and really pushed the envelope so that we would treat earlier in MS. Beta-seron, as I talked about, was the first one we had available to treat MS and was shown to decrease mortality in patients with MS over the long haul. Copaxone was the Uncola. So it was the non-interferon, so the no flu-like reactions from the shots, and has maybe some unique benefits in primary progressive MS. Xtavia is a second generation. It's beta-seron, basically. Another company took it over. Glatiramer acetate and Glatopa are Copaxone in generic forms. Kesimpta is a once-a-month shot. It's a monoclonal antibody with a good bit of teeth to it. So it's a B-cell depleter, kind of like Ocrevus, but in a sub-Q form that you take monthly. It's been approved in the last couple of years. Plegridy is a long-acting Avonex. Then we have Rebif, which is another interferon like beta-seron that came and was, for a while, because of how they structured their studies, the first medicine that actually had significant impact in all those three things that we're looking for in NIDA. Aubagio, one of our first pills, and the only MS medication with 2 phase 3 studies that show a statistically significant benefit in reducing disability progression. Bifiratam, probably haven't heard of that one, and that's a banner that Stu was talking about at the beginning. So a new one to the market, and this is a it's a monofumarate, a monomethyl fumarate, whereas Tecfidera is a dimethyl fumarate, and Vumerity are dimethyl fumarates. They get broken down to a monomethyl fumarate, which is what Bifiratam is. So it's the broken down product of those two medications, and claimed to fame with a little less GI irritation. So the dimethyl fumarate is now a generic of Tecfidera, which is now on the market. Gilenya was the first oral pill, and we were fortunate to be the first clinic in the country to give it commercially back in 2010. And so it was a welcome sight. All the people with their lumps and bumps and red spots and bruises from the shots welcomed the first pill that we had for MS, and is a very effective treatment. Mavenclad is a unique medication, and that you take this pill 5 days first month, 5 days the second month, then you give it a break for a year, and then take it 5 days that next month and 5 days the next month, and then see what happens. May not need to be treated. It's a ... see what happens as time goes on. Mayzent is the next generation of Gilenya, and Ponvory, also the next generation from that, as is Zeposia. So they were pills that modified that first dose monitoring. So with Gilenya, you had to come to the clinic and be monitored for pulse rate and such for 6 hours with the first dose. And anytime you missed it for 14 days, you had to go back and do that 6-hour monitoring. Well, these medications made it so that you don't have to do that. Vumerity I talked about. Lemtrada is an IV treatment that you take 5 days in a row for a year, then take 3 days a year later, and then ... may never need to be treated again. It's kind of wait and see what happens with very good long-term results. Novantrone isn't used very much. It was used around 2000 a lot because it really stopped progressive disease. It would shut down that we can't stop this condition. Unfortunately, leukemia, 1 in every 150 people emerged, and there's heart failure if you take more than 8 to 10 doses. So we already knew that. We're limited by that as far as length of treatment, but it really stopped some people who were really going down fast, and it was a godsend at the time. But then unfortunately the leukemia became an issue, and we had other treatments that came, so it's kind of fallen down. I still give it once in a blue moon to help people where there's not a whole lot else to do. Ocrevus is an IV treatment every 6 months, and it's a B-cell depleter, knocks your B cells out and keeps those antibodies from attacking the myelin and the B cells from turning on T cells to cause more damage. And that hit the ground running. Then COVID came, and worse outcomes with Ocrevus than any other treatment. Worse doesn't mean fatal, it just means they had more issues for a while. Now that we've had vaccinations and people have had COVID, now they have memory cells to the vaccine and to the COVID, then it's not a problem. Because when you wipe out B cells, you can't make antibodies to new viruses or bacteria mainly. You can't make new antibodies. So COVID was a novel thing. But all the vaccines from before, measles, mumps, they're unaffected when you wipe out the B cells because there's this memory pool. And now there's a memory pool to COVID in a lot of people. So Ocrevus now, again, is a appealing choice, whereas if one was sort of sickly and so on, didn't want to necessarily add that to the mix for a little while, but that's kind of letting up now. And then Tysabri, the once-a-month IV treatment. It's also a monoclonal antibody, been around a long time. Lots of really good success in halting disease progression. Has a risk of a brain infection, PML, if you have the JC virus, so that limits its use in those individuals. But came out in about 2004 and was a very welcome treatment at the time and still used a lot. In fact, there was a study that came out this week, I think that said 6 years after on Tysabri, no brain atrophy. Just like normal aging, no change in atrophy, whereas MS normally 10 times faster brain atrophy untreated. The other treatments do have impacts, but this is one that was a paper just shared that's 6 years and no brain atrophy at 6 years on that treatment. So here's kind of the market share. We don't talk about this. This is what's happening out in the country. This is how often medications are prescribed. And this was the last run, the percentages of medications that were used. And you see Ocrevus is out in the lead there, up near the top at 18%. I just wanted to show that there's a whole variety of medications listed here, right? This is the national VA market, treating veterans, our veterans. Not as many choices there. And our local VA, there aren't any IV, there are no patients on IV treatment. No patients, or a couple patients on oral medication, but they're still taking the 1990 medications. And there was so our big American Academy of Neurology meeting occurred a few weeks ago in Seattle. And one of the presentations was African Americans and Hispanics get the injectables more often and progress more. This is not acceptable. Okay, which I agree. We need to be very vigilant in everybody from the get-go. And there are some risk factors in some that would make us want to be more aggressive in treatment earlier. And this would fall kind of in that same category, that they're not offered or given treatments that are what considered high efficacy. They're on essentially low efficacy medications. And I would just dare say that that's not acceptable. Well, letting Coach K leave on a loss, that was acceptable to me. He went out 50-50 against UNC. His record was actually 50 wins, 50 losses. So he didn't fare too terribly there at the end. But for the veterans, there is an insurance that they can get called Veterans Choice Insurance, which I think a lot do get. And if you have that insurance, because of a 2018 Missions Act, they can request to receive care outside of their VA and will be granted care outside of the VA. So if they're not getting the care that they think they should, they have another avenue from this act. And maybe there are some of you out there that didn't know that and maybe stuck in a certain situation, but you need to know that there maybe is another way. Okay? So how do we manage MS? Well, I think of 3 boxes, or here circles, of medicine management for MS. We treat relapses, we prevent disease progression, hopefully well, and then quality of life box. I talked about kind of the preventatives, all the DMTs. I just gave a little bit of a pearl of those medications. So talk about relapses. So is it worth treating a relapse? Well, when you have an active lesion in the brain, for every cubic millimeter of dye that's taken up, there are 11,000 snipped axons or wires. And I know Dr. Boster, I watched one of his presentations. He's a great MSologist from Ohio. And he says, I talk to the spouses of someone with MS, and I say, how much damage will you accept, will you allow for your spouse to have? And he goes, none. So if there are a lot of relapses, active lesions, this is not acceptable. So yes, a relapse is worth treating because the longer inflammation goes on, the bigger the scar is going to be, and the more baggage you have to deal with down the road. So yes, we should treat relapses, even if it's just sensory, lost my feeling in this left side of the body. Well, if you ask people who've had that kind of a relapse a few years later, they said, well, I should have been more aggressive with it because now I can't button buttons or I drop items, and it's frustrating. It wasn't the I'm paralyzed or weak. And we used to do that in the 90s. It was, well, that's a mild relapse. We've already given steroids. I don't know if it's worth giving steroids again in someone. We learn as we go along. So IV steroids need to be given before oral steroids. There's an Opticneuritis treatment study that was done that showed that when you gave oral first, that set up more problems down the road as far as more relapses go. Have to prime it with IV. Now we can give oral steroids for general inflammation if someone's having a relapse because they're having inflammation in their body elsewhere, that's acceptable. But if it's actually inflammation inside the central nervous system, if at all possible, oral steroids should be primed with IV steroids beforehand. Acthar is ACTH, and that's a medication that's a substitute for steroids because not everybody can tolerate steroids or benefit from steroids, so we have another alternative. And there are others as well. The other thing we need to do with relapses, because no one teaches you this, if you have a relapse and you start to get better with the steroids and then and then it becomes weak again, you need to know you need to contact the office because this happens all too often. Well, those steroids, I thought they were going to do me really good. I got my arm function mostly back, and then after a couple weeks, it started fading again, and they show up for an appointment 3 months later, and the scar is sealed, right? So we need to monitor during a relapse. We need to educate people that, hey, if you start to worsen again, you need to let us know because the inflammation is now outdueling the dose of steroid that we're giving you, and we may have to bump that, or we may have to switch to another treatment to really get control of this relapse. So Acthar, just kind of a slide to say that it has areas or receptors that are not where the steroid works. So one might say, well, it's kind of a me too. It works on generating your own steroids in your body, but it doesn't. It has different receptors, so it can work when steroids don't. So when you come to the doctor finally and after relapses and so on, you're left with some baggage. So that's what we address in clinic most of the time, is quality of life. How can we tweak this, do that, ameliorate this symptom or that symptom? So symptom management, it doesn't affect directly whether you're going to have more lesions or not. It doesn't affect that part of your MS. It's designed to improve your quality of life. And you need to, just because we have a medication or a treatment doesn't mean you should take it. If you had tingling in your left pinky for a year, I have some medicine that probably can stop that. But if it's not interfering with anything, you're going to put something in your body regularly to control that at a cost and interaction with other medications. Maybe that's not the wisest thing to do. So So it's weighing out. We have medicines for most all symptoms of MS, but it's weighing it out. Is my quality of life really better for having taken it? And that's taking cost, side effects, convenience, et cetera, into play. And with symptom management, there's certainly a lot of non-pharmaceutical things to do, but there's just not a lot of time. So I'm going to kind of concentrate just to give you a feel for things that we have available or at our behest that might treat some particular symptoms. All right, so symptom management medications are not FDA approved. Most of the time they weren't designed for that, but we find that they're very helpful. Otherwise, you don't have anything. And unfortunately, we fight with the insurance company every day, multiple times. Oh, it's not FDA approved for that, can't get it. Well, there's really not anything FDA approved for that, so they just suffer. So it's a battle. Oh, well, there's a generic something you can give. So it's a struggle, it's a constant struggle, but just they didn't go through trials to prove that they were effective with this symptom that is a byproduct of an MS attack. The big enemy in MS, this is the enemy. And it comes in lots of ways. 90-degree temperature, that's a stress on your body. Cold, that hurts. That's spasticity and pain. Heat's fatigue. Difficulty at home, that just makes a lot of the symptoms a lot worse. Infections, that's a stress on the body. Not sleeping well, missing meals, dehydrated, smoking, those are stresses to the body. And they make MS symptoms worse. They're modifiable and non-modifiable stressors, right? Some, child had a terrible illness. Can't do a whole lot about that. But someone's really annoying and likes to hang out with you a lot. Might be able to do something about that one. And then on the other side, over-volunteering. At church and other places, that's good work, but you just have to see is it leading to a stress that's impairing my ability to be a light to the world, right? So and saying no, MS patients are typically very big-hearted and hard to say no. And my scribe, Eric, who many of you probably met, we were just kind of noticing in the last month and a half, well, how are you spending your time is my typical question to start off the visit. And it's working. And I was like, did you notice that about 90% of our patients are working and 90% of able-bodied people in this country are not working? There's something wrong with this picture. But it's because you will, and you have a gumption and passion to do good things and right things. And sometimes that can get in the way, and you have to put the pause button on and say, it's too much for me. So it's just kind of do a self-check every so often. When it overflows, then we have impaired conduction. Okay, so when you have a scar, and people wonder, how does this happen? How do I get worse because of stress? Well, when you have a scar in a pathway, that pathway is functioning suboptimally, but may be adequate for your general activity. But when you stress the body, it cannot pick up the juice to take on the increased stress. It's sort of like Christmas lights. If you have a plug that allows 3 strings and you put a 4th one on, not working, right? And so if you add stress to the body, that system, which is working at maximal capacity, just can't do it, and you're going to have that paralysis in the right side, that numbness on the left side again, until the stress calms down. And I like stress in a cauldron because I think there's multiple things that contribute to stress, and it just all adds up. And when it gets to a certain level in that cauldron, then you're going to be affected. Your MS symptoms are going to be affected. A lot of hidden symptoms. So a lot of patients really frustrated, and it comes at the spouse and child level often, because, in fairness to the spouse or the child, you look fine. And we go around judging people by how we look at them. We can't interview everyone in the day. How are you feeling? How are you feeling? We look at him, and the guy has an unshaven beard, and his shirt's hung out, and his hair's all like this. Well, he hung one on that night, right? And we know what he's feeling, right? So we can tell. But someone who has fatigue of MS, you often cannot tell. And they say, I'm tired, and the spouse is like, mm-hmm. And often won't say something, but the little light bulb's going off, right? And people don't understand. That's fatigue, the number one disabling symptom of MS. It's not a visible symptom often. And anxiety depression is a symptom, but it's also a comorbidity, which I'll talk about in a minute. And then these are some of the other things. I'm not going to go into each of them, but if you had optic neuritis, if you're dizzy, if you have pain, what you're feeling on the inside, if your bowel bladder don't work, those aren't typically visible things. So you contend with a lot of issues that nobody knows. They don't know what you're going through. And in fairness to them, how would they? So when they say, well, why don't you? Why can't you? They're not inside you. They don't understand what that's like. And if they don't get educated on this condition, there's this mismatch, right? And just like if you never had the condition and your spouse did, you probably wouldn't understand the things that you're going through now that they would be going through, right? So education's important on hidden symptoms, so they kind of go hiding away. Overall common symptoms, there are a few others that, someone who has speech difficulties, strength problems, spasms, cramps, those are visible. So there are some visible symptoms as well. I'm going to talk about them sort of briefly before I get yanked on the symptoms. MS-related fatigue, number one disabling symptom of the number one disabling neurological condition in the world for young and middle-aged adults. It is a real player. It adversely affects quality of life. In 50 to 60% of people, their worst problem. 80% of people are typically affected to a noticeable degree. It's just those scars drain the battery. And right now, standing here, if I move, my leg is feeling my pants go rub against it. I don't notice it all day long. I don't even have a clue that that's happening. But it's stimulating a pathway. And if there's a scar in that pathway, it's draining a lot of energy. So even if you're not doing a lot of overt things, you are working pathways that have MS in it typically, and you're going to be fatigued. It's really poorly understood other than there's mitochondrial problems and the scars chew up a lot of energy just to transmit across them, but there's probably a good bit more to that. Heat sensitivity, it's related to depression. It predates other symptoms. Typically, a lot of times patients, you look back at before they were diagnosed, they'd been to the doctor several times, fatigue being one of the major things. Managing fatigue, so we want to take care of spasticity, that stiffness. If you go around like this, you're chewing up a lot of energy if you're flexing, right, like my teenager. So he's chewing up a lot of energy, and if you did it all day long with your spasticity, you're wasting a lot of energy that's not doing anything good for you. So treating spasticity can be helpful, making sure we're treating depression, make sure that we're letting you sleep well at night, which is a big issue. Energy conservation, don't do things in the heat of the day, etc. There are a lot of different things that add up to try to help mitigate the fatigue somewhat. I'm just going to move on from fatigue. Speech dysfunction, it can come in a lot of ways, and probably the most common that I hear in clinic, I can't find the right word, right? I can't, I know what I want to say and I can't say it. Or similarly, I have a thought and I'm trucking along and then it just vanishes. What was I saying? Right? Those are not memory problems. And a lot of patients think that those are memory problems. They're not memory problems. They're frontal lobe problems. You formulate words in the prefrontal area, it goes across to the motor area for speech and then down, and it's in between here where most of the scarring is that interferes with your ability to come up with words. It's not in the temporal lobe where your memory is. So cognitive dysfunction used to not be appreciated at all. As when my mom grew up, she said, well, two good things. If there's anything good about MS, you'll never have any pain and you'll never have any cognitive problems. So that was in the 60s and 70s. Quite different now. And we know cognitive issues, multitasking, just being able to state a task and find the right words, remembering things. really intimately associated with fatigue. The more fatigued a person is, the more likely they're going to have cognitive issues. And on the contrary, treating the fatigue often improves cognition. So someone comes in, they think they have two problems. I have fatigue, I have cognitive problems, I have this, I have that. No, you have one issue, and that's fatigue. And if we improve your fatigue, your cognition's going to get better. You're not going to bump into the door frame because you're not tired and just didn't pick it up so well or cleared the door as well. So treating fatigue really can help a lot of these other symptoms. They're interrelated. So where's that? Barcelona, yeah. So Sagrada Familia, the world's largest church, is not quite finished, but they want to do it in the next 6 years on the 100th anniversary of the death of the person who made that Gaudi. So it's quite an impressive thing. So it makes my cognition kind of, when looking at it, it's amazing. Visual difficulties, so optic neuritis is the most common. You can have double vision, nystagmus, which is that bouncing vision. You can have an internuclear ophthalmoplegia where they think you should be on a horror movie and one eye goes that way and the other goes that way. Those are issues. Typically the INO does not affect vision very much. My mom had it and it was pretty significant, but she didn't have issues really with seeing because of that issue. It's more visible than it is a problem usually. The others are more of a problem. So optic neuritis, 25% of the time, that's the presenting relapse of MS, and over 50% of people with MS will have optic neuritis during their course. You have up to 6 months to get vision back, so if one didn't get care right away, there's still value in treating it and trying to restore vision. Double visions in the brainstem, and the type of double vision, whether it's side by side or on top of each other or diagonal, kind of tells you where the lesion is and can help. If it goes on for a while, then prisms can help. Too often people get care too soon for their double vision and they go get a prism in their glass and they're still kind of healing up. So they heal more and now they see double because the prism's in the way. And so you want to wait till it's kind of a stable double vision if you're left with that before you get the prisms in, but they can be extremely helpful. Nystagmus, that bouncing vision, there are several things to try to help calm that down because that can lead to nausea and dizziness. Numbness, if it's on one side, usually the problem's going to be up in the noggin. If it's both hands and it works its way up, it's going to be likely in the spinal cord. If it's in your feet and it works its way up, or it comes up one side and down the other, then it's most likely in the spinal cord. And you need to know that because if your doctor orders a brain scan, they're not going to see the lesion that's causing the problem. All right, so one-sided, most often it's going to be in the noggin, maybe in the high cervical cord, but bilateral symptoms that are the onset of bilateral symptoms is almost always going to be in the spinal cord. That MS hug, that wrap that goes around both sides, that's a lesion in the cord to cause that problem. So another park in Barcelona. Yeah, so weakness, you don't want to have weakness looking at those stairs. And weakness also, unilateral or bilateral. If it's bilateral, think about spinal cord as the place that's causing the problem. And the biggest physical disability in MS occurs from lesions in the spinal cord because they affect mobility. So motor on one side, maybe it's in the brain, both sides definitely in the spinal cord. And how many people have heard of dalfampridine? How about Empira? That's the other name for it. So a lot of people don't. And we write more than anyone in the country by far. But it's amazing to see people come in and they have some weakness in a limb and they're dragging their foot somewhat and they've never tried Empira, which is called the walking pill. And it helps restore signal. And it's the only treatment to improve that can improve weakness. Okay. We used to get it when I was at UAB in 90, we'd get it from London because we didn't compound in the US at the time, and we'd get it for heat-induced fatigue. So it's called the walking pill, but it's really for endurance. It's for things that fatigue out. So there's fatigue and there's fatigability. Fatigue is I just don't have anything in the tank. Fatigability is I start out walking or moving pretty well and then it deteriorates pretty quickly. That limb doesn't move as well. And Empira is something that can bring that function back. When you lose electricity to a limb, you typically don't use that limb very much. And then what happens is you get atrophy. So now you have loss of electricity and muscle shrinkage. The problem is compounded. The weakness you can overcome that's due to atrophy with use. So it's typical not to use something that you don't use very well, but we would encourage the opposite. Use it a lot in spurts. You can't use it for very long, but build that up. And Empira and physical therapy can be a really good combination if you're trying to treat some of that limb weakness. Here's a scar. And what happens is the signal that's coming down hits that scar and it shorts out in the potassium channels, goes out. And so you only have partial signal. Instead of that robust, big, fat, white arrow, now you get this little stringy arrow going out. And so you get some signal to the leg, it moves somewhat, but it's not very good or for very long. And then how Empira works is it blocks the shorting out path to the potassium channel, so more signal effectively goes forward, okay? And you'll know within 60 days whether it helps, so it's not that you're married to it once you get on it. If it's not helping, and I would dare say that for any medication, if it's not working for you, we don't want you to take it, okay? Spasticity is the stiffness, and this is Prague, beautiful river. Think about that, you think about bladder dysfunction. So I was in the Navy, had someone watching me, you'd have to turn on the sink to be able to give a sample. So the bladder can be a problem with spasticity. I gotta go, and you go a little bit, and then you go back to your room, and then, I gotta go again, and you let a little bit out. That's a spastic bladder. And the other thing is, I just found out I have to go, and you better get out of the way, because my bladder needs to empty. So that's more of the spastic bladder. Really can lead to a lot of problems. Again, a hidden symptom, but a lot of it happens more commonly in women, and it's like, don't want to have intimacy, because I don't want to leak during intimacy. You know, things that really aren't talked about at home or in the doctor's office, but it has socially isolating qualities to it. 30–40% of people don't leave the home as often because of bladder-related issues, and that's terrible. So there's lots of medicines to try. If one doesn't work, try another. Dry mouth constipation, typical side effects of these, which doesn't help much, but we try to navigate and find the right one. And then pelvic floor therapy has come screaming onto the circuit. So you have speech therapy, physical therapy, occupational therapy. Well, during the pandemic, pelvic floor therapy came. And these are certified therapists who it's Kegels on steroids plus a whole bunch of other things that you've never experienced before. So, women, again, more often affected because the bladder to the outside world is a short distance. Hormones occur, and then you have MS. So those things really lead to a lot more difficulties with bladder, and pelvic floor therapists can really, they've helped quite a number of our patients to get off medication or make them to have a lot more time to be able to get to the restroom. The other type of bladder is the lazy bladder, where it doesn't have nerve supply and it just sits there, it doesn't empty, and it overflows. And that's a more vexing problem. Catheter is sometimes needed for that condition. Sometimes we can use some medications that help the bladder to empty. Constipation is the most common problem, though some people have the opposite. They run off all the time. So that can happen due to MS, but it's usually constipation. Constipation it's more than just, I'm not comfortable, I feel a little bloated. You're not moving anything forward. You're not absorbing your medicines. You're not absorbing your nutrients. They're not as effective. So it has much bigger impact on a person than just it's a little bit uncomfortable and haven't gone in a while. So it's important to treat that and move things forward. Sexual issues, hardly ever talked about. Men, it's more mechanical. Women, it's usually sensory or dryness or inability to have an orgasm. Those are kind of more the problems. Again, not talked about, not brought up a lot, and we as hesitant doctors don't broach the subject a lot of times, and we should, because intimacy is important. So if that's an issue, I'd suggest you discuss that. We have a number of different things. There's the pink pill now. So the blue pill is for male function. The pink pill is for women's interest. So it's a daily pill that you take at night for loss of libido, and it has a name, so it's Hyposexual desire disorder is the name of the condition, and that medication is approved for that. Now, whether an insurance company pays for it, that can be a battle sometimes. So there's a lot of different things that we have, not just medications or shots. There's make sure that testosterone levels are fine. There's a bunch of things to do for that, so if that's an issue, I'd encourage you to bring it up. Difficulty swallowing. A lot of times that's due to spasticity, and the esophagus gets really tight. And if you can relax the esophagus, make sure that you're hydrated, because a lot of times we're dehydrated because I don't want to drink because I don't want to go to the bathroom, so I'm going to be dehydrated. And I'm dehydrated, my mouth's dry, and then I choke on the cornbread, right? It kind of goes and goes and goes. So we have some things that may help with dysphagia. Sometimes there's a neurostimulator that, just like a TENS unit, that can sometimes help with the esophagus. Sometimes it needs to be stretched, but there are a number of things to do for that. And pneumonia from choking, letting things go down the wrong tube, is a serious consequence of significant dysphagia. Well, this was painful, going to the plains to watch Alabama lose. But so pain is very common in MS, and trigeminal neuralgia, that shooting, lancinating pain in the face, is probably the most known. But there's a lot of pain elsewhere, and unlike how it was appreciated in the 60s and 70s, pain is present in 40-50% of people with MS. And a lot of times it doesn't respond to narcotics, it responds to anti-seizure medications. They work best for neuropathic pain typically, but there's a lot of other things to do. How about comorbidities? Do we know what that means? That means you get a package deal. You get MS plus depression, plus sleep disorder, plus restless legs, plus this and that. Genes travel with genes. And so comorbidities are conditions that you inherit along with your MS. Depression and anxiety, most common. And the others are listed there, much more common in MS than in the general public. So depression and anxiety are not mental health conditions. They are physical problems of the brain. There's chemicals that are not in sync, norepinephrine, dopamine, serotonin. They're a physical problem that happens in this noggin right here, not over here where insulin and glucagon's a problem, or in another place where there's another problem. No different. You shouldn't be treated differently because you have depression and anxiety. Oh, you need to pray more. Oh, Johnny across the street's in a wheelchair. What are you so sad about? Your fault. It's your fault that you're depressed. It's like, are you kidding me? No, it's a genetic thing that the person happened to get as a package deal with their MS, and then you're hurling this on top of them. It's kind of like Salem's Lot when we burned the epileptics for seizures because we thought they were witches. Well, we treat people with depression and anxiety really pretty poorly. We think a person should be able to control it, and if not, go see the psychiatrist. It's a physical problem of this organ. And it manifests itself in ways that maybe make us feel uncomfortable by seeing someone anxious or down, and we can't help, so we're going to make the situation worse, usually, by picking on them. But this is 50% of people with MS typically will have depression or anxiety at some point significantly in their course, and it gets undertreated. Now, depression's kind of acceptable now. You can go have your Prozac or your this or your that. That's acceptable in society, but Xanax, Valium, Ativan, Klonopin, that's not allowed. No, those are addicting medications. They're terrible. You shouldn't be on them. You live with your anxiety. No, you have anxiety, we have medications. And a non-benzodiazepine we like to try first, and some of the antidepressants have anti-anxiety properties. That's great, but they're there for a reason, and they're very helpful. And the thing that we see with the stimulants for fatigue, with the anti-anxiety medications, and with pain medications is typically when you're trying to get normal, you don't have a problem with addiction or a problem with these medications, habituation. It's when you try to be extra normal. I'm going to stay up extra to do this. Well, the brain gets used to that. You drink a six-pack every day for a month, six-pack not going to do much for you anymore. You're going to need 10 or 12, and then you're going to need a case. Well, same way with these medications. If you're using them for feeling a different way that's not normal, the brain's going to say, I need more to to be stimulated that way. But if you're just trying to get my anxiety, I just want to be normal, there's no escalation. The brain doesn't say I need more. It says that's good. And a lot of people who take those medications on the taboo list, when they take it, they say, I felt like a normal human being for a change, but I feel guilty. I feel guilty because I'm taking that medication, right? But they don't need to. It's monitored. We control the prescriptions. So, if you have anxiety and depression, I'm not saying you're automatically going to go on medications like that, but those are part of our treatment plan in some people, and you shouldn't feel ashamed or bad about having those conditions or seeking to have those treated. Okay? We know red flags of people who are getting out of hand with those sorts of things, and we can limit that problem if it would ever happen. And so I'm just going to show them so that they're on the video when people look back.
I'd love to go on and on and on and on and on, but there are planes to catch, people to see, and things to get going
Florida's
for, right?
nice.
I would have loved to have heard all these conversations, all these dialogues.
These are going to be the latest medications.
Okay, just talk about BTK1 and then we're done.
Okay, excellent.
Right?
Good. I knew I could get to. So these are 3 medications in phase 3 clinical study. They work the same way. So they're a Bruton kinase or tyrosine kinase inhibitors. So tyrosine kinase is an enzyme that moves phosphate to tyrosine residues. You don't have to remember that. But it occurs in the receptor. It occurs in receptor and non-receptor type. In MS, the ones that affect the non-receptor type are the most important and really selectively affect B cell function. So unlike some of our medicines now that kill B cells, these actually affect the function without killing the cells. And they have a lot of assistance also maybe in the innate immune part, which is microglia and macrophages, which possibly lead to remyelination. So not saying they do, but they work on a system that may repair damage in the brain from MS. But they most importantly, in how are being studied, are studied to cut down relapses and attacks and look to be very effective. So this is the next hottest thing on the radar screen right now. They're all in phase 3 study, so these medications will likely be amongst us in a year or so. There was a study at the American Academy, looked at T cells from people who'd recovered from Epstein-Barr virus, and it stabilized or improved people 24 patients at a year. So this is the first go at this as far as maybe remyelination, repair, and a different way to treat MS. So, now I'm done.
Yay, hello.
Thank you.
My sincere thanks to Dr. LaGanke. Even though we spoke about on and on and on how he's going to stay to 60 minutes and have no problem, when I saw he's got 100 and something slides, I knew that wasn't going to work.
And my grandkids, I have to show
my
my 4-year-old grandkids had a birthday last month.
Exactly.
So have to show.
All right, well, thank you again for speaking. All right, first question. Why do so many neurologists say women don't need treatment after 60?
Well, I don't know that that's particular for women. I haven't heard that, but there's this concept of burned out MS, that after a while the immune system just stops causing inflammatory lesions and it kind of burned out, and we don't need to keep taking a medicine if we're not preventing things that aren't going to happen, is kind of the concept. There was a study in looking at that in people 65 and over who I believe had no disease activity for 10 years, no relapses, and on treatments. They were taken off treatments. About half of them had relapses, so in their 80s and such. So they said, we're not going to do that. Another follow-up study showed much better results, and a third study, I'm not sure if it's complete yet, but is underway or almost done or done, that is looking at that concept again and then seeing if they can kind of further refine and say, well, people who've been stable on this with this kind of MS are ones who may not need to be treated. So we don't want people to take treatment if it's not helping them. So we'd love to have some kind of evidence that said that you're highly likely not to have to take this anymore and your MS is kind of quieted down or burned itself out. But we're not completely there yet. But I think that's maybe the concept is that it kind of burns out.
recent studies or whatever are connecting Epstein-Barr. Epstein-Barr causes MS. What if you've never had Epstein-Barr and you have MS?
So, very good question. We've known this for a long time. It's just happened to have a study, and so it's getting a lot of splash now. But we knew Epstein-Barr was likely one of the causes of MS from a pediatric study that was done many years ago. 95% of adults have evidence of having had Epstein-Barr virus. So not 95% of people have MS, so doesn't absolutely cause MS in everybody. And then there are some rare 5% people who haven't had Epstein-Barr virus and they still get MS. So it's not the cause of MS. There's not one cause. There are many, many different genes, and someone may have gene A, B, and C, and human herpes virus 6 is their trigger for MS, and someone over here has A, X, and R, and Epstein-Barr is a trigger for their MS. So it's not everybody, but Epstein-Barr is a nasty virus. But in the pediatric study, kids don't have Epstein-Barr virus at the frequency that adults do yet. And so did a pediatric study, looked at kids who had MS, and when they went to the ER with their relapse, and they chose age-matched kids, and they saw a much higher percentage of kids with MS having Epstein-Barr than the kids who didn't. So we've known that for a while. So we know that Epstein-Barr is likely a cause of a bit of MS. And Epstein-Barr nastily gets into your DNA. So it inserts itself into your DNA. And, we have start signals and stop signals. Well, it gets in there, it moves things around, so things change. And, cancer is unfortunately a consequence in some people of Epstein-Barr virus, and it causes a whole host of things that we probably still haven't determined. But yes, I believe it is definitely important in propagation of MS, but it's not the sole cause of MS.
Okay, online question from a Cindy. There is more than one Cindy online today. I have a question about my mouth shifts to the side when talking. Why?
Well, if MS is at hand, which I presume it is, you can have facial weakness. Very commonly, just out in the lay public, Bell's palsy causes weakness or drooping of a side of the mouth when you talk. And MS can cause weakness in that same pathway, though it's doing it in the brainstem, not in the nerve. And so it can cause weakness that comes out once you stimulate the muscle and it goes one way. Now, if it's directly over to the side, that may be a different muscle than the facial muscle that causes that. There are several different muscles that are important in facial movements and jaw movements. And so there's likely a lesion in the brainstem, if it's related to MS, that causes that to happen.
All right, next person, Edith, writes, can you first get MS in your 70s?
Rarely, yes. So we've diagnosed a few people in the 70s. It's most typically between 20 and 50. The diagnosis, a good 80% of people are diagnosed in that age range. But there's a number that are less, down to 18 months of age. And then there are some in their 70s. And I think even it's probably reported a few in their 80s to be diagnosed. But not very common, but it can happen.
Could it be more probable that they actually had it years prior and just diagnosed in their 70s?
Probably some things that weren't recognized, or they were fortunate that the lesions just didn't interfere with vital pathways.
Okay, thank you. Next one, another Cindy writes, I'm so grateful to your mom for teaching your compassion. As a longtime patient of yours, I can honestly say I have never had a doctor with the perfect mix of compassion and knowledge that you have. I am forever grateful.
Oh, thanks, Mom. Yep. Thank you.
By the way, I wear a mask because I look better, right?
Look younger.
Thank you.
Thank you. I have a question about the pelvic floor therapy for women. I'm interested in that. What's involved in that, and what if there's a diagnosis of a cystocele?
I can answer that if you can't.
You can?
Yeah, I can.
Well, look at Stuart. So you may augment my answer, maybe.
Sure, we could do that.
So, Yes, I think they can be partially. The cystocele is kind of the bladder that's kind of dropped in. It has the cyst that pouches out, and that's not going to be fixed by pelvic floor therapy. But the other issues that maybe led to it and such may be assisted by pelvic floor therapy. As far as what's involved, I haven't been, so I don't know the ins and the outs. But I know that they coach you on waiting a little bit longer, or different cues and signals of things that you pay attention to. They work on strengthening pelvic floor and vaginal walls. There can be a stimulator that's put on your ankle that can affect the bladder, so it helps to, because that nerve around the ankle comes out of the spinal cord, the same place as the nerve that goes to the bladder. So by stimulating that, you can strengthen the nerve to the bladder and help. They have a lot of tricks, a lot of things that they can do that way. Typically you'll go and then they'll give you homework. So you don't have to go like physical therapy every day or 3 days a week. You'll go do some things, come back, they'll assess how things are going, give you the next plan, work on that. So it's generally not as in-office intensive as some of the other therapies. And
thank you. So we've had a pelvic floor specialist speak for us many times. Her name is Karina Siracusa. She's out of Columbus, Ohio. We did a virtual program with her a couple of months ago. So she's online. She's on our YouTube channel. So you can go there and listen to her entire talk. And she'll be back speaking with us again in May live when we're right outside of Columbus doing a live program, but she'll be there with Aaron Boster talking about pelvic floor exercise. So, but there's a lot of it online. I mean, if you want to know even more, I mean, what Dr. LaGanke said was excellent, but there's so much to be seen online about this. You could Google search pelvic floor exercise and it'll tell you everything. So a person was asking about what's happening with all the MS medications as they lose their patent. And, what they're calling the next set of medications that are out there for them, such as the biosimilars.
I had a list in the talk about some of the generics or biosimilars that are available. So those are ramping up as medications lose their patent. Then those medications are free to be manufactured and distributed from any company. So after the patent's up, and I think a 6-month period after the patent's up, then other companies can make that same or a biosimilar product. So that's happening already. And the cost goes down. Insurance likes that, so they like generics. I'm not exactly sure how the biosimilars in the MS space, what they have to meet, but in regular generics, you only have to maintain 80% the effectiveness of the brand name, and you could be 120% on the other, 20% on the other side. So there can be a 40% difference between generic medications. And that can be a real problem if you have epilepsy, stroke, MS. If you're taking something that hasn't been studied and you have a 40% swing in the treatment, maybe that's important. Biosimilars, I think, are held to a little closer standard to the brand name item. But often the generics don't have the company support. So they don't have people that help teach how to give injections. They're not there to help with copay assistant and so on and so forth. It's just, here's a generic medication. So some of the niceties go away when others come up. But of course, there's a huge problem with costs and cost of medications, and that needs to be addressed.
So going further with that, and this includes me as well, the medication that I've been using since 2009 is losing its patent at the end of this year, and I don't want to switch, as do a lot of people do not want to have to switch, right? So how do we stay with our brand medication?
Well, I think it's coalescing, coming together, and making the argument that this biosimilar maybe wasn't tested. And so why would I take something that I don't really know is the same, because they haven't gone through trials to prove efficacy. And I don't want to take a chance with my MS. I've been controlled for this length of time, and I feel comfortable with this, and there's a system in place. And as generics come out, there's going to be hiccups in distribution of product just because those companies are kind of new to the space and so on. And that leads to maybe not taking medication and relapses and permanent neurological loss. So I think getting together and arguing that point and promoting that might be of help.
So a lot of what I'm going to ask you has to do with me already knowing the answers, but they don't. So that's why we're bringing this up, all right? But even with the generics that are out there, so many of the generics aren't made with the same actual compound. And so, people are getting worse. And unfortunately, they do not have the mouthpiece or know the people to actually help them get back on it. How do we get the neurologists to better understand what's going on with their own patients? Okay, and yeah, the MS neurologists see it. Okay, so maybe they have a little bit more pull. But most of the people in the United States see general neurologists. And how do you get them to, those people to wake up and see what's happening to their patients and fight more for them to be able to get it through, whether it be private insurance or government insurance?
Well, as you said, we're kind of blessed in being an MS center that we say, no, we don't want this person to have generic, and a lot of times that's successful, and we're able to maintain treatment, but that is not everywhere. So it's, I guess, talks like this and patient advocacy and patients going to their clinician and saying, no, I don't want to do this unless there's evidence that this medication has been tested in a similar fashion and or post-marketing evidence that there's no change and no novel side effects. I don't want to do this. I think the risk is a relapse leaves you permanently changed 50% of the time. Who wants to take that chance? Right? Now, and I understand cost is a big problem, and that issue has to be addressed as well, because these medications, beta-seron was, $15,000, $12,000 back in 90. It's, as with all of them, average $80,000 for what's going on with that out-of-control steamroller, right? And so that has to be addressed, and some people would take generic because their copay is going to be next to nil, and they can afford to get some food and are put in that position. So, that's a separate issue, but an important issue. But I think, to answer your question, it's going to be advocacy and in numbers.
Correct. And so for anybody out here that wants to be part of that advocacy, the National MS Society needs you. Okay? They really do need you. And by the way, I'm part of the ISA review committee coming up.
Very good. Well, and the MS Society has kind of gone away from being local, so it's more national. So that touchy-feely part that we were accustomed to having isn't quite there, but they would take it, the positive is they'll take it from all the states and send it to New York, because everything gets put there. So they'll have more numbers than just 20 people in Alabama. They'll have thousands of people from around the United States. So contacting the MS Society and making that known, and hopefully they send it up the stream, and then all the states are doing that, we'll have a better chance.
As a remyelination medication becomes available, what is the realistic outcome for a person that has physical disability?
That's a great question. Since we don't have any, don't know what the mechanism is going to be and how far gone is too far gone in a scarred pathway. You would hope that, and I'm sure that the more black holes there are and axon loss there is, it's going to be harder to remyelinate those ghost segments. But if they're not there, even if a person has significant loss of use of motor function, if you can re-insulate, that I would expect that there's going to be regain of function. So wistfully, and I'm more the half full glass, that remyelination will help people who've had motor problems for a long time. I mean, one of our treatments that we use quite frequently, we've had people who've had a numb limb for 11 years regain their function and feel that, and they just kind of do that all day in the clinic because they're so happy they can feel their foot. And other people who've walked who are confined to a wheelchair. So I know in people who are significantly affected, they can respond even if they've had it for quite some time. So the hope would be that remyelinating agents would do that as well.
What are the symptoms of MS, and what is the determining factor?
Well, there are a lot of symptoms, and I showed a couple of slides that had a partial list of all of the symptoms that one can have, anywhere from numbness to weakness to visual disturbances to fatigue to dizziness. Pretty much anything that comes from the brain and spinal cord, those pathways can be affected. In fact, during application for residency, one of the places they interview, they go, what neurological symptom can occur that doesn't occur in MS? And really not it may be one or two, but really anything can be affected in MS that comes from the brain and spinal cord. The way to diagnose it, there are certain criteria. They're not absolute, but they're a really good guideline on how to diagnose MS. Typically, you have a change in space, different areas of the brain, and time, now and sometime later. A change in space and time with disease means that you have multiple sclerosis in the absence of other conditions that mimic MS, because there are conditions that look exactly the same, both physically and on MRI scan, and you have to do those blood tests to exclude those conditions before you make a diagnosis of MS. So if someone has a neurological event, it lasts at least 24 hours, and then they have another event at some point down the road, that's a sure way to diagnose MS. There are ways that, fortunately, in the last 5 years, we have pushed to diagnose with the first attack, not wait till another area is clearly damaged. So if you have an attack and you have lesions, you have multiple lesions, and you have something found on the exam that's accountable by another lesion, or if you have an active lesion somewhere other than where you're having your event, that's enough for us to be able to make a diagnosis of MS. So we can make a diagnosis of MS sooner now and don't have to wait for that second attack, but that's the classic way to do it.
Thank you. We have time just for like 2 more questions. So if anybody's out there, raise your hand. I'll get over to you. Otherwise, we got one online. And that is, why don't they prescribe sildenafil more to help with brain signals?
So sildenafil is Viagra, the other way to say that word. So, and there is some suggestion that it can help in motor pathways in the brain. I think it's not been clearly shown in MS patients. So again, insurance companies don't want to pay for something that hasn't been proven in clinical trials. So I think that's probably the hiccup as far as sildenafil being prescribed. It is generic now, which has helped a whole ton in being able to prescribe it for problems with intimacy. Both had a lady yesterday, and she goes, "I don't need a pink pill. I have desire. I have a blood flow problem." And so Viagra would be something that we've used in women who have that kind of an issue with some success. So we can use it a whole lot more readily, and maybe we will see that as a byproduct that there's better motor connection and so on and so forth, and that will lead to another indication, but it just doesn't have that indication right now.
How's that? Call
Thank
it a
you.
big wrap. Thank you very much. Thank you. It was great seeing you again.
It's great getting out again.
It's great getting out
Thank
again.
you.
It's great doing for everybody again. It's a wonderful feeling to be able to provide these programs and have a full audience, all right? Thank you.